Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for critical care medicine. There are some changes you'll need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. Let's get started. Preparing for ICD-10 today will provide you guidance to appropriately document your critically ill patients in the future. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, write acute on chronic congestive heart failure rather than congestive heart failure. Use due to or secondary to indicate cause and effect and to record all conditions the patient may have, such as acute systolic heart failure due to or secondary to hypertension. Think about the most current terminology to describe a condition or different aspects of the disease. For example, paroxysmal versus persistent atrial fibrillation, or typical or type 1 versus atypical or type 2 atrial flutter, or systolic versus diastolic heart failure, or both. Precisely designate anatomical site, such as acute deep vein thrombosis of left tibial vein. Use exact dates when appropriate. For example, when a patient is admitted for acute myocardial infarction and the patient previously had a recent MI, document the exact date of the recent MI. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. In ICD-10, there is a feature called laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs, or those codes specific to one side of the body versus the other. For example, acute left otitis media. ICD-9 has a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes, additional documentation will typically not be needed. So for your information, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat. For example, pressure ulcer of the left ankle. So do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. As physicians, we know what the clinical term acute coronary syndrome means, but in ICD-10, acute coronary syndrome is assigned to the non-specific diagnosis code of acute ischemic heart disease unspecified. If you can describe ACS more specifically as intermediate or insufficiency coronary syndrome, unstable angina, or coronary slow flow syndrome, these terms rather than ACS should be documented and will result in codes that give a more accurate picture of what you are treating. As in ICD-9, ICD-10 classifies myocardial infarction by type, STEMI versus non-STEMI. New in ICD-10 is the ability to report the site or location of a STEMI by coronary artery affected. If at the time of diagnosis you don't know the coronary artery, document as much as you do know, such as the wall of heart affected. Note that no additional documentation is needed for the location of non-STEMI. Here are some examples of ICD-10 codes for a STEMI. Note that the codes are first categorized by anterior or inferior wall, then additional specificity is provided for the coronary artery. Also note that certain terms crosswalk to certain codes. For example, a transmural myocardial infarction of the inferior wall is coded to other coronary artery. The key here is describing the MI as specifically as you can regarding the type and location in terms of the artery, wall, or other site affected. Unique ICD-10 codes are used to identify patients who present with an MI that is occurring within 4 weeks of a previous MI. When a patient is admitted with an MI and the patient has a history of a recent MI, document the date of the recent MI, the type as either STEMI or non-STEMI, and in the case of a STEMI, the wall of the heart that is affected. We see here in this example of medical record documentation that the patient presented with an acute STEMI of the LMCA, and the patient had a history of non-STEMI last month. Improved documentation for ICD-10 includes either the exact date of the previous non-STEMI or the number of weeks since it occurred. ICD-9 provided a single code for cardiac arrest. ICD-10 provides the ability to report the cause of the cardiac arrest when known or suspected as due to an underlying cardiac condition or other condition. ICD-10 also provides codes for intraoperative and post-procedural cardiac arrest, either due to cardiac surgery or another type of surgery. Your documentation should indicate a cause and effect relationship by using words such as due to or secondary to. ICD-10 terminology describing congestive heart failure remains essentially unchanged from ICD-9. However, there is currently an opportunity for improvement in documenting this diagnosis. To provide an accurate picture of the patient's severity of illness and risk of mortality, you should specify whether the patient's congestive heart failure is acute, chronic, acute on chronic, and whether it is systolic, diastolic, or a combination of both. Additionally, you should document the cause or etiology of the congestive heart failure when known or suspected. An example of excellent documentation would be acute systolic heart failure due to possible or suspected alcoholic cardiomyopathy. New terminology in ICD-10 provides the ability to report the type of atrial fibrillation as paroxysmal, persistent, or chronic, and atrial flutter as typical or type 1, and atypical or type 2. When you can more precisely describe these conditions, these are the terms you should document in your notes rather than just atrial fib or atrial flutter. What stays the same? The etiology of cerebral infarction or stroke is still classified primarily by whether it is due to thrombosis, or embolism. What's new? ICD-10 has lots of new codes for cerebral infarction, which identify the specific artery involved and, when applicable, whether right or left. For example, you see here the codes for cerebral infarction due to thrombosis of the anterior cerebral artery. Keep in mind, coders can't get the details of the etiology, site, or laterality from ancillary services reports, such as radiology, since coding must be based on what you document. So be sure to include these details in your notes. Also new is that ICD-10 provides codes for a cerebral infarction that occurs intraoperatively or postoperatively during cardiac surgery or another type of surgery. It's important to make sure your documentation clearly indicates at which point in time the infarction occurred. As you can see here, ICD-10 provides different codes for a non-traumatic subdural hemorrhage specified as acute, subacute, or chronic. Once again, ICD-10 allows you to report how sick your patient is through the reporting of acuity, so be sure to differentiate the type in your notes. Also note, code I62.1 is reported for non-traumatic extradural hemorrhage when documented. Unique ICD-10 codes are reported for traumatic brain hemorrhage of the sites you see here when you include this information in your notes. Additionally, you have the capability to report any associated loss of consciousness and how long it lasted. For example, one code is reported for loss of consciousness up to 30 minutes, a different code is reported for up to 59 minutes, and so forth. So include this information in the patient record. The only thing new here is that ICD-10 combines the anatomical site and the stage of the pressure ulcer into a single code. This required two codes in ICD-9. As you may be aware at this point, coders can use nursing or physical therapist documentation for the stage of the pressure ulcer, but you must document the diagnosis of pressure ulcer in your notes in order for it to be coded. It is also important to indicate if the pressure ulcer was present at the time of the patient's admission. ICD-10 uses the term hepatic failure instead of hepatic encephalopathy. Additionally, ICD-10 provides for the ability to distinguish between acute or subacute and chronic hepatic failure, and with or without coma, which when documented will allow the reporting of how sick your patient is. Additionally, codes are provided for hepatic failure due to drugs, which you are encouraged to specify. It has been my experience that physicians often document the signs and symptoms of hepatic failure, for example, confusion, altered levels of consciousness, or coma, without actually documenting the underlying condition itself. So if your intended or suspected diagnosis is hepatic failure or hepatic encephalopathy, that is what you should document in your notes. But you also need to specify whether it is acute or chronic, with or without coma, and specify the etiology of hepatic failure, such as alcohol dependence. Obviously, it's appropriate to include the signs and symptoms in your notes, as long as you also include the diagnostic terms of hepatic failure or hepatic encephalopathy. The coding for a gastrointestinal bleed or hemorrhage in ICD-10 is very similar to ICD-9. However, it is important to identify the etiology of the bleed, if known or suspected, and link it to the hemorrhage. We see here in this example that the patient has hematemesis and esophageal varices. However, there is no link or cause and effect relationship made between the two. An example of improved documentation would be acute GI bleed due to bleeding esophageal varices. What is new with urinary tract infections is that the diagnosis of urosepsis can no longer be coded in ICD-10. In ICD-9, a diagnosis of urosepsis defaulted to the code for an unspecified urinary tract infection. If you record a diagnosis of urosepsis in the ICD-10 environment, it will generate a query asking you for clarification. If by using the term urosepsis, you mean the patient has a UTI, then document UTI. If you mean the patient has septicemia from a urinary source, make sure to document this. For example, E. coli sepsis due to UTI. There's not a lot new with urinary tract infections in ICD-10. If you know the site of the infection, it's important to note it, such as cystitis, urethritis, or pyelonephritis, and if the condition is acute or chronic. If the infection is related to a device, you must document this relationship, such as UTI due to indwelling Foley catheter. Lastly, if you know the organism causing the infection, make sure to document the cause and effect relationship in your note, such as E. coli UTI. There is not a lot new with regard to the documentation of acute kidney failure in ICD-10. You must specify the etiology of the acute kidney failure, if known or suspected, and whether it is acute tubular necrosis, for example, or as a result of trauma or a procedure. You should avoid using the term acute renal insufficiency when you mean acute renal failure, as insufficiency is assigned to a generic or non-specific code in ICD-10, which will not do justice in explaining your patient's severity of illness and risk of mortality. Not much has changed in ICD-10 with regard to the documentation of chronic kidney disease either. You must specify the stage of CKD, stages 1 through 5, or end-stage renal disease. Additionally, you must also indicate the etiology, such as diabetic CKD or hypertensive CKD. Try to avoid using terms such as chronic renal insufficiency and chronic renal failure interchangeably, as they are coded differently and will result in inaccurate classification of your patient's severity of illness and risk of mortality. Classification of asthma is an example of the use of updated terminology in ICD-10. Asthma is now classified as mild intermittent or mild, moderate, or severe persistent. Documentation of acuity remains unchanged from ICD-9. You should continue to document the presence of an acute exacerbation or status asthmaticus. For example, a diagnosis of severe persistent asthma with acute exacerbation is classified to J45.51. Classification of pneumonia and pneumonitis is very similar to ICD-9. It continues to be important for you to document the type of pneumonia, for example, aspiration pneumonia, and the organism, such as Klebsiella, when known or suspected. Remember, a coder cannot base code assignment on a sputum culture or cytology report. You must document the organism in your note, indicating a cause and effect relationship, such as Klebsiella pneumonia or pneumonia secondary to or due to Klebsiella. ICD-10 differentiates COPD with acute lower respiratory tract infection from acute exacerbation of COPD without infection. When an infection is present, Document the specific infection and organism when known or suspected. When respiratory failure is present, it should be specified as acute, acute on chronic, or chronic. Dependence on supplemental oxygen should also be indicated when applicable. Most types of emphysema were grouped into a single ICD-9 code. What's new in ICD-10? Separate codes are provided for specific types of emphysema. When you document the specific type of emphysema, such as unilateral, panlobular, or centrilobular, a unique ICD-10 code for that condition can be reported. What's new here? ICD-10 has a new combination code to capture the patient who has a pulmonary embolism with acute cor pulmonale. The takeaway here is the documentation of cor pulmonale and whether it is acute or chronic. What stays the same is that you still need to document the type of pulmonary embolism, such as septic or saddle, and whether the pulmonary embolism is acute, chronic, or healed or old. History of PE can be interpreted to mean the patient has had the condition for a while, such as in history of hypertension, or interpreted to mean the patient no longer has the condition. Documentation of chronic pulmonary embolism versus healed or old PE makes a clear distinction and assures that the severity of illness of your patient is reported accurately. Severity of illness is increased when a patient has a chronic pulmonary embolism, but there is no impact on the severity of illness when the patient has a personal history of pulmonary embolism. Note that documentation of healed or old PE results in the reporting of a code for personal history of pulmonary embolism. ICD-9 did not differentiate between a diagnosis of respiratory failure and acute respiratory failure. The good news is that ICD-10 does. When appropriate, you should document respiratory failure as acute, chronic, or acute on chronic. Additionally, also specify if hypoxia or hypercapnia, or both, is associated with the respiratory failure. Remember, coders cannot interpret the results of tests such as arterial blood gases. They must rely on your documentation. At times, we see respiratory insufficiency and respiratory distress used interchangeably with respiratory failure. Respiratory insufficiency and distress are signs and symptoms of an underlying condition and are coded differently from respiratory failure in ICD-10. Be clear on your intended diagnosis. Severity of illness will not be reported accurately if you use one term when you mean another. Additionally, document the cause or etiology of respiratory failure, such as due to COPD, surgery, or trauma. When pulmonary insufficiency is due to surgery, documentation should describe a cause and effect relationship, and it should be further described as acute or chronic. For example, acute pulmonary insufficiency due to surgery 2 days ago. FYI, one of the differences in ICD-10 is that pulmonary insufficiency due to surgery will be classified as either due to thoracic or non-thoracic surgery. What's new in ICD-10 with the sepsis continuum? Sepsis is classified to one of two categories in ICD-10, either streptococcal sepsis or other sepsis. Streptococcal sepsis is further specified as being due to Group A or Group B streptococcus, Streptococcus pneumonia, or other streptococcal infection. As mentioned earlier, the coding professional cannot use laboratory results such as a blood culture to code an organism, making it necessary for you to indicate a cause and effect relationship between the organism and the sepsis if known or suspected in your notes. There are now combination codes for severe sepsis or SIRS due to an infectious process with acute multi-organ dysfunction with or without septic shock. It is important to document shock as well as any associated organ dysfunction, such as acute respiratory failure, acute renal failure, acute hepatic failure, disseminated intravascular coagulopathy, and so forth, as they are important indicators of severity of illness and risk of mortality in the critically ill patient. Sometimes we use the term sepsis, bacteremia, septicemia, and severe sepsis interchangeably or indiscriminately in medical records. Make certain to clearly document the term that accurately describes your patient's condition and update it should the patient progress along the sepsis continuum as the condition is treated or resolved. On another note, should you have a patient with SIRS due to a non-infectious process such as trauma, ICD-10 requires you to document if there is associated acute organ dysfunction. There's not much new with shock in ICD-10. However, it is important to specify the type of shock your patient may experience, such as cardiogenic, hypovolemic, post-procedural, post-traumatic, or septic. The documentation of these conditions gives a more accurate picture of your patient's severity of illness and risk of mortality. Where ICD-9 used 2 or more codes to classify diabetic complications, ICD-10 uses 1 that captures the diabetes, the type of diabetes as type 1 or 2, and the diabetic complication, if any, such as diabetic nephropathy. Additionally, ICD-10 does not primarily classify diabetes by control status, as was the case in ICD-9. However, inadequately controlled, out of control, or poorly controlled diabetes gets reported with a second code that says the patient is a diabetic and is currently hyperglycemic or hypoglycemic. These terms for control status are more reflective of the terms that we as physicians use, and that alone is responsible for this change. It remains important to document diabetic patients whose blood sugar is not controlled because these patients require more resources to treat. Malnutrition is an underdocumented condition in the elderly. However, it is also an important indicator of your patient's severity of illness and an important influence on performance metrics such as readmission rates, length of stay, and quality outcomes. If your patient has malnutrition, you should document the clinical picture, the type, such as protein calorie or protein energy malnutrition, and the stage or degree. For example, mild, moderate, or severe, or first, second, and third degree. Your notes should include clinical findings such as patient with terminal cancer, 20-pound weight loss, and cachexia, and any supporting labs such as low albumin. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant and taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated conditions. For example, patient was admitted due to acute exacerbation of systolic heart failure. Patient has age-related dementia and forgot to take her digoxin as prescribed. Or, patient cut her dose in half this month because of financial issues. What's new here is that a diagnosis of depression without further qualification is coded to F32.9 in ICD-10, which is the code for Major Depressive Disorder, Single Episode, Unspecified. In ICD-9, a diagnosis of unqualified depression was assigned a code that simply said depression. If major depression is not your intended diagnosis, consider adding additional details to your documentation when known. It will change the code and better describe what you are treating. For example, major depression could be further specified as single episode or recurrent. In either case, is it mild, moderate, or severe? If severe, it is with or without psychotic features. Is your intended diagnosis something else other than major depression, such as adjustment disorder, for example, grief reaction, with depression and or anxiety depression, or depressive neuroses? According to published Medicare inpatient hospital data, the code for unspecified depression appears on 1/5 of hospital records covered by Medicare. We can do a better job identifying patients with major depressive disorders as compared to those with other forms of depression that are less severe and require less resources. We'll take a look at a few procedures that may be performed in a critical care unit to give you some exposure to ICD-10 PCS codes and associated documentation requirements. Here you see the table the coder will use to construct the code for a balloon pump. Of particular interest is the column labeled duration. The coder must be able to determine from your documentation if the balloon pump is being used intermittently or continuously in order to assign the PCS code. For example, if documentation was for continuous duration, the procedure code would be coded as 5A02210. In this example, you see the table used to code a pericardiocentesis. The root operation definition for this procedure in ICD-10 PCS is drainage, which is defined as taking or letting out fluids or gases from a body part. It is not necessary for you to document drainage of the pericardial sac. Rather, the coder will review your procedure note and identify the PCS root operation that best describes the procedure performed. Pay particular attention to the column labeled approach. The coding professional will need to be able to determine from your notes if the pericardiocentesis was done via an open or percutaneous approach in order to construct an accurate code. Even though the chances are that most bedside pericardiocenteses are done via the percutaneous approach, the coder cannot make this assumption and must rely on documentation of the approach in your procedure note. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.